Good afternoon, everyone. Thank you for joining ICL and Precision Analytical for this afternoon's webinar featuring Dr. Carrie Jones. Dr. Jones is a naturopathic doctor whose passion and expertise lies in the areas of hormonal, adrenal, and thyroid health. She recognizes that imbalances can occur at any age and believes that it is important to look at the big picture, such as appropriate use of lab testing. Dr. Jones graduated from the National University of Natural Medicine in Portland, Oregon, and went on to complete her residency in women's health, endocrinology, and hormones. Later, she graduated from Grand Canyon University with a master's of public health and a goal of doing more international work in health empowerment. Dr. Jones is an adjunct professor at NUNM and regularly consults, lectures, and writes on the topic of hormones, thyroid, adrenals, digestive issues, autoimmune, and more, both nationally and internationally. As the medical director for Precision Analytical, her goals are to provide ongoing, cutting-edge, integrated clinical education to the large network of providers paving the way of healthcare with functional medicine. Dr. Jones will present this afternoon on comprehensive hormone testing with the Dutch test. Take it away, Dr. Jones.
Thank you, Amy. I appreciate that. Love the introduction, and thank you to In Common Laboratories for hosting us and me and letting me talk about comprehensive hormone testing with the Dutch test. We will start out the lecture going over some basics, and then we will move into Dutch testing, and then we will go into a lot more of the clinical pearls, sort of the key neat things about the Dutch test beyond just what do you do with low progesterone. So let's start right at the beginning. Let's start at some female basics, and then we'll move into men about halfway through. So ladies, just FYI, in case you've forgotten, you were born with about 2 million follicles. By puberty, though, we're only left with about 300 to 400,000 follicles on our ovaries, and we lose about 1,000 follicles every month through atresia. We do release, of course, one egg at ovulation. So it goes through follicular genesis, where one egg is chosen to be the winner of the beauty pageant. And that's the one that goes on to either, right, become fertilized and become a baby, or not, and resulting in a menstrual cycle or your menses. So follicular genesis is going from your primordial follicles into your pre-ovulatory follicles. And how long does follicular genesis take? Well, it takes about 3 months. And so this is why I generally use 3 months as my guideline for when I'm working with any woman about any condition, including fertility or PMS or endometriosis or PCOS, because it takes about 3 months to get that primordial follicle up and healthy and developing so that when you ovulate, you will have really good lutein cells or a corpus luteum and subsequently good progesterone production. So you've got to give it about at least a 3-month window before deciding whether or not what you're doing is working. Also, as a reminder, let's just go through the menstrual cycle quickly. In the follicular phase, what happens is your period is near the end, right? You're kind of done with bleeding. Your estrogen is declined and your inhibin A stimulates FSH from the pituitary. And as FSH increases, it stimulates follicles to grow in the ovary. Now, this, of course, is starting to happen at the end of the period, obviously in the early follicular phase. So this is why FSH is tested on day 2 or 3 when it's sort of at its highest, because it's really trying to tell that, the follicles on the ovary, like, okay, move forward, let's do this. So that growing follicle makes estrogen, and if you forget how, it does it through aromatization. So your theca cells on your ovaries make your androgens, and then your aromatase right there in your ovaries aromatize in the granulosa cells and to make estradiol. So now your estrogen is starting to increase. And as estrogen increase, it's telling the brain to choose the main egg to be released, so that rising estrogen and the inhibin B suppresses FSH at this point. So now FSH goes back down. And what happens is you get this sustained estrogen surge. And research tells us you need about, believe it or not, 40 hours of sustained estrogen surge. It's that pre-ovulatory estrogen surge that then results in the LH surge from the pituitary. And of course, the LH surge causes the egg to release about 18 to 36 hours later. Now, from the start of the surge to the end of the surge, from start to finish, is 36 hours. They say 18 to 36 hours because it depends where you test them. right? If you're doing an LH predictor kit or an ovulation predictor kit, you don't know if you're catching the LH in the urine on the way up at the top or on the way down. And so you've got kind of a buffer there. And then of course the egg has about roughly 24 hours to be fertilized before it too naturally dies. Now, the leftover cells, your theca and your granulosa, turn into your corpus luteum. They turn into your lutein cells, and they start pumping out progesterone. And as we know, progesterone is warming. Those of you who track your cycle with temperature will see your body temperature levels go up, hopefully about a degree, and then you'll know that your progesterone is getting produced in a healthy manner, hopefully. A healthy luteal phase is about 12 to 16 days. Anything shorter than that is considered luteal phase defect. If you're not pregnant, then of course the hormones fall and that triggers menstruation. And if you become pregnant, then the corpus luteum should hopefully continue to make progesterone until your placenta's able to take over around weeks, somewhere in the weeks 10, 11, and 12-ish. And we know that if somebody has their placenta is not able to take over, or if you have a weak corpus luteum, then you're at a risk for miscarriage due to the lack of progesterone. This is why a large number of practitioners, both functional, naturopathic, and even conventional, will check progesterone with a positive pregnancy test, because you want to know right away if you can just put her on progesterone and reduce her risk for low progesterone miscarriage. For those of you who are visual, this is the normal menstrual cycle. This, of course, is your up-down of estrogen, progesterone, FSH, and LH that we've all seen multiple times as we move through. Now, what happens as you get older and you move into perimenopause? Well, unfortunately, about 1,000 plus follicles are lost to atresia every month. And as women age, the health of our follicles may be less than desirable. Of course, our follicles are very impressionable to things like stress and chemicals, and our diet, genetics plays a role. And so that those two things combined, the loss of follicles coupled with maybe not as healthy follicles as when we were quite a bit younger, leads to irregular hormone production. And she doesn't have those granulosa cells to make estradiol or theca cells to make androgens, and or the quality of follicles to produce those proper hormones. And now she enters perimenopause. And as most women who are in perimenopause can attest to, they feel that irregularity, right? There's symptoms of hot flashes or night sweats, or joint pain, frozen shoulder, insomnia, anxiety, their menstrual cycles. It all sort of comes and goes as this irregularity of production occurs. And that's how we know that somebody is in perimenopause. Eventually, though, the entire process stops. We don't have follicles to listen to the FSH and LH. So FSH and LH rise, but yet the estrogen and progesterone are quite low, and now she enters menopause. She's considered menopausal when she's gone 12 full months without a menstrual cycle. She can still be symptomatic. She may be 18 months post menses and still says, I have hot flashes, brain fog, vaginal dryness, what have you. It's not the symptoms that defines it, believe it or not. It's actually the cessation of the menstrual cycle. So when she's 12 months, she's considered menopausal. So now, knowing this, the most common question I get is, okay, when do I test my patient? Well, in particular, today we're talking about Dutch testing, and therefore we're talking about androgens, estrogens, progesterone, and we want to make sure we're testing all of that in the luteal phase of her cycle. So if she is still cycling regularly, then we're looking roughly day 19, 20, 21 of a typical 28-day cycle, or we say 5 to 7 days after a positive ovulation test. And of course, many women automatically are doing ovulation predictor kits that they just buy at their pharmacy or grocery store at home. I will often have women say, well, according to my app says I should be ovulating. I'm like, nope. I mean, that's great you track it on your app, as you should, but you have to take into account your signs and symptoms for ovulation, because the app might tell you that you ovulate on day 14, and yet your cervical mucus is changing and you're actually ovulating on day 12. And because the egg only lives about 24 hours, if fertility is your objective, you could be missing the window. And of course, we all have stories as practitioners of people who just following the book and having intercourse on day 14 when really they should have been doing it on day 12, or even later on day 16. And so that's why it's so helpful to actually, to track beyond just an app. If she says I have long cycles or I have short cycles, but they're regular, they're her normal, you just shift up or down accordingly. Still track her ovulation, still see if she ovulates, and just do the math to decide if she's to collect sooner than, of course, day 19, 20, or 21, or later than day 19, 20, or 21. If she has irregular cycles, still do the ovulation predictor kit or track ovulations until she has a positive test, and then do the hormone test 5 to 7 days after that. Now, the other option is to figure out why she's irregular and then address that and come back to the testing. If she's irregular because she has a hypothyroidism that is not quite yet controlled, if she's irregular because of, PCOS, you may want to, and these are known things, you may want to address those things first, because if you do a test, let's say in the month of August, but she's irregular, you don't know if September is going to look just like August, or even, October for that matter. So just keep that in mind. You can always test, but just be aware it doesn't mean the months look exactly the same in an irregular cycling woman. If she doesn't ovulate and she's completely irregular, definitely call the lab. We will walk you through questions like, what is her age? Is she perimenopausal? When was her last cycle? What's going on with her? What were her last couple of cycles? To try to narrow down the window of when she should collect. For example, if somebody says, well, my patient is 48 and she hasn't had a cycle in 6 months, when should I test? It's like, well, she's 6 months into the menopause, just go ahead and test. It's probably fine. But if she's 21, you're going to maybe address it a little bit differently than somebody who's 48. So call the lab and we can help you walk you through an ideal time when to test. Menopausal women, of course, can test on any day, as there is no luteal phase. And if she is on the oral birth control pill, the patch, the ring, the injection, please use caution with hormone testing and remember the mechanism of action of the pill, the patch, the ring, or the injection. Their purpose is to shut down the hypothalamic pituitary ovarian axis. And so if you have a shut down HPO, then you're going to have low levels of endogenous estrogen and endogenous progesterone, because those things just take over. So when you test, you may find the estrogens and progesterones are very, very low in the menopausal range, which is normal for the mechanism of action. It means that those things are working. Her birth control is working. You can absolutely still test. You can still look at her androgens. You can still look at her estrogen metabolism. You can still look at her cortisol, and you will just know all of her markers are related to the fact that she's on the pill, patch, ring, or injection. So it's not a contraindication. You just have to remember what you're looking at. So what does Dutch test? Let's dive into what the test looks like and what Dutch tests before we sort of move on into male testing. So Dutch tests a lot of things, and these are your options. We have a Dutch Complete, which is our dried urine flagship test. We have the Dutch Plus, which is a combination of dried urine and saliva swabs. This does include the cortisol awakening response. And all things cortisol and the cortisol awakening response, I did talk about in another webinar. So definitely look that up, because I won't be talking about that in today's webinar. We do have the Dutch cycle mapping, which we will be talking about in a future webinar. So stay tuned for that. That is probably by far my most favorite test for the cycling woman, because you just get so much information through her whole menstrual cycle, especially those women who say, I have symptoms on these days, right? I'm symptomatic on days 14, 20 through 24, and then 28 the day before my period. Or women who say, I get migraines that start on day 24 moving forward, or I get migraines at ovulation and before my period. And so it's really nice to see the rise and fall of the estradiol and of course the progesterone through the whole month. And then we do have the Dutch CAR only, which is only looking at the cortisol awakening response. But again, that's a different webinar, not this webinar. However, I did want to make you aware that we do have that testing ability. So if we do look at the Dutch Complete, which is what we will be going over today, it is all dried urine, meaning your patients will urinate on pieces of filter paper 4, if not 5 times throughout the day. and it will give them their androgen markers and androgen metabolism, their estrogen markers and metabolism, progesterone metabolites, their metabolized cortisol and cortisone, their free cortisol and cortisone, and of course, if they have insomnia and wake up in the middle of the night, they're definitely able to test that extra fifth strip so that we can see what's going on. We do graph it out, the cortisol out, as a diurnal pattern, so they can see the up-down pattern, or down-up, or flatlined, depending on the health of your patient. And then, of course, we have the Dutch extras, including the organic acid metabolites, the nutritional markers, melatonin and 8-OHDG. The Plus really has everything that the Dutch Complete does include. However, the Dutch Plus has your cortisol awakening response. So if you want everything the Dutch Complete has and you want the cortisol awakening response with it, which is where we hyper focus on that first 30 and 60 minutes of the day, then absolutely look more at the Dutch Plus, because you will still get all the metabolism markers, don't worry, and you will get the pattern, and you will get the cortisol and cortisone, and you will get the Dutch extras. We just give you a little more information with that cortisol awakening response. In the Dutch Plus, we do also have an overnight saliva swab. So if you have a patient who has cortisol awakening issues and they have insomnia, we got you covered. We can do it both. So if they wake up at 3 in the morning, you can collect a swab and we'll tell you what their cortisol and cortisone are at that time. So if we focus just on the Dutch Complete to give you an example, it's again 4, if not 5 strips collected through the day. You do first collection on waking, then 2 hours later, around dinner and before bed, and if they wake up in the middle of the night. The collection device picture is listed there, and they just urinate on it, set it on the counter, and let it dry before mailing it back to the lab. Just be careful wherever you set it, because they are very enticing to little kids and dogs. And if they get eaten by animals, your patient will have to collect. And believe me, we've heard our fair share of funny stories of people who've collected their urine only to find out that their animal has run away with it. So let's look into the test results so you have an idea of what I'm talking about. Let's start with the female test results. So this is an overview of what the hormones all look like put into dials. Now we do list out all the examples, or excuse me, all the results in a single on a single page. But what we want to do is it's much easier to look at it from a visual perspective when we look at these dials. And so this, for those of you who are new to Dutch, this might be really overwhelming. So let's break it down first. So what do those dials mean? So first of all, the range in between the stars is the range for a luteal phase woman. So you read the dials like a gas gauge. So in between the stars is for somebody who would be in the luteal range. And on the left-hand side is a little purple rectangular box, and that is the menopausal range. So you can see the progesterone example is on the left and the estradiol example is on the right. And then you will know if they're in the luteal phase or if they're in the menopausal range or kind of in that gray area in between. Now, why do we give both ranges on the dial? We give both ranges because we don't know where you want your patient to be. So for example, if you want your menopausal woman to be in the luteal range, then we're going to give you the range on the dial so you can see how much further she has to go, or if you have her on some sort of supplementation. Same goes if you have a woman who's down in the postmenopausal range, yet she's 24 and should be cycling regularly. It will give you an sort of eye-opening visual experience of like, oh my gosh, she's 24, she's in the postmenopausal range. We need to figure this out on why she's so low. So we do give you both ranges for every person. It is also very helpful for the perimenopausal woman who is kind of irregular and swinging up and down, where you can see where she falls on the dial, because she's not menopausal yet, but she's not yet, or she's not quite where she was, back a few years ago when she was cycling regularly. So we do give both. And so here's an example just to show you, does this woman have quote unquote low estrogen? And of course, it depends on her age. Like I said earlier, if she's of cycling age, then yes, she does have low estrogen. This is like the 24-year-old example. She's down in the menopausal range. Assuming she collected at the appropriate time of her cycle, then this is too low. If she's menopausal, then no, not necessarily. She's right in the menopausal range, and if she's not symptomatic, then this is working right for her. Or if she's on some kind of supplementation or therapy, and you're looking to see where she is in the menopausal range, you can just look right there and go, yep, she's right in the purple box, right where she should be. So if we break down each section, this is progesterone and the progesterone metabolites. So we don't actually look at progesterone in urine, but we look at its two progesterone metabolites, alpha pregnanidyl and beta pregnanidyl. Now, beta pregnanidyl is the most abundant progesterone metabolite in the human body, male or female, it doesn't matter. However, we feel at Dutch that we need to give you both the beta and the alpha, because that will give you the true representation of how much progesterone she had circulating around. And it's the alpha pregnanidyl, it's the A version, that goes on to create allo, ALLO, and that crosses the blood-brain barrier and can bind to your GABA A receptors. And so that helps with anxiety, that helps with insomnia. And so if you have a woman as she's getting closer to perimenopause and even menopause, and she says to you, my anxiety is up, my insomnia is worse, what is going on? The fact that she's not ovulating and she's not making progesterone means she's not making as much alpha pregnandiol like she used to. And so you can help support that. Now, unfortunately, I get asked a lot, well, my patient is very beta dominant. Can I switch her to alpha? You cannot. Not to my knowledge. There's no magic herb, there's no magic nutrient. There's nothing that I can do to actually switch her out of the beta and over to the alpha. But what we can do historically is we use oral or sublingual progesterone, which I know in Canada you can't use yet, especially if you're a naturopathic doctor. But your laws are always changing, and it's possible you're going to get to use it in the future. But the oral, what happens is it breaks into a lot of metabolites. When it goes through first pass, many of those are the alpha. Those cross the blood-brain barrier, and that's why it's so helpful. On Dutch, we do look at the estrogens, your phase 1 and 2 detox. So let's look at that. We do look at your E1 estrone. We look at your E2, your estradiol, and we look at your E3, your estriol. Then we look at your phase 1 metabolism. This is your 2, your 4, and your 16 hydroxy. So this is where your E1 and E2 get converted into phase 1. And then we look at where you go from hydroxy to methoxy, and that's your phase 2 metabolism, which we will talk about more towards the end of the lecture. We do not look at phase 3 estrogen metabolism. That, of course, is when the estrogens go from the methoxy out of the cell into the bile, and then subsequently out the intestines. So if those of you who want the complete phase 1, 2, and 3, you will have to combine Dutch testing with stool testing to get an idea of what their phase 3 looks like. So then we look at androgens for females, because of course that's very important. We look at DHEA-S, which is the sulfated form. We look at testosterone, and we look at the androgen metabolites. So we look at etiocalanolone and androsterone. And this is really nice because it gives you an idea of that 5-alpha reductase activity. And we will talk about that later in the clinical pearls. Let's switch over to men, the male patient and male Dutch test results. So quick facts. Testosterone is highest at puberty and starts to decline 1 to 2% yearly at 30. However, unfortunately, what's really common nowadays is that this process is really sped up through poor lifestyle habits, dietary choices, toxic exposures, lack of exercise, increased stress, resulting in men in their 20s and 30s experience the fallout of a low testosterone level. And I think we see this all the time, those of us who work with men in hormones and endocrinology, that men are coming in younger and younger with low testosterone, low androgen levels at large. We used to see men maybe more in their late 40s and 50s and 60s with low testosterone. And now, sadly, it's not uncommon for a man to be in his 20s and have the testosterone of a 60-year-old. It's very crazy what's happening to men and their testosterone. Male factor infertility is about 30% of the cause of infertility between couples, although this percentage is debated. And in fact, many fertility experts feel this percent is actually quite a bit higher, that male factor infertility is a lot more. Prostate cancer is the most common form of diagnosed cancer in men. To keep that in perspective, non-melanoma skin cancer is the most common cancer overall, but may not be necessarily diagnosed. And then lung cancer is the most common cause of cancer death in men. So it's not prostate cancer. That's the most common cause of cancer death, but it is the most common diagnosed in men. For those of you who need a visual as men age, this is from 1993, and you can see as testosterone declines, SHBG, sex hormone binding globulin, goes up. And we know now with research that this decline is actually happening much more rapidly, unfortunately, because of all the reasons that I stated in the earlier slide. And then lastly, when it comes to testing, why do we test testosterone in men early? Please do not have your men just randomly go to the lab at 2 o'clock in the afternoon to get their testosterone checked. That is not going to be helpful. Testosterone is made at night in deep sleep in the Leydig cells of the testicles. And because it's made in deep sleep, it's highest in the morning. And so men get that testosterone rise, which often leads to that other rise. You know what I'm talking about. And so please, when you're testing testosterone, make sure they go right when the lab opens, early in the morning, to get the most accurate result, because it's made through the night in deep sleep. So let's review testosterone and sperm production, just in case you're not as familiar. The hypothalamus tells the pituitary to make LH, just like in women, men have LH and FSH as well. And that binds to the Leydig cells in the testes, and that produces your testosterone, your androstenedione, and your DHEA. Now, obviously, some DHEA, of course, is made in the adrenals, but the testicles make the majority of the testosterone and the majority of the androstenedione, like 99% is made there. But FSH binds to their Sertoli cells in the seminiferous tubules and develops nurturing sperm. So if you can't remember, just remember the S in FSH is for sperm, which means LH is testosterone. So this is what I think is really, really neat. There are 6 stages to seminiferous development. Going from stage 1 to stage 6 is called a cycle. Each cycle takes about 16 days. Most sperm need about 4.6 cycles to fully mature, which is about 74 days-ish, depending on the guy. So I'd said earlier, folliculogenesis for women takes 3 cycles, which is about 90-ish days, right? Give or take. And for men, when we're looking for healthy sperm, we're looking at about 74-ish days. So when it comes to the health of his sperm with fertility, think back, what was he doing 74 days ago? And is that the healthiest sperm available? So it's going to take a man some time, right? 4.6 cycles to get his old sperm out and the new sperm to be that much healthier and to really feel the impact of whatever treatment that you're doing for them to improve their count or their morphology or what have you, the viscosity. So 74 days to get his entire sperm back to A grade, just like it will take about 3 menstrual cycles for a woman and her ovaries and her follicles. So men, we do look at androgens, of course. We look at DHEAS and testosterone, just like in women. And we look at lots of metabolites, just like in women. We do, on the visual, show the DHT in men. While we report it in women, we do have it on the visual in men, just because of DHT's effect being a little more pronounced and when it comes to men's health. And so we will talk about that 5-alpha when we get a little later in the lecture. With the Dutch extras, let me go back for a second. In men, like I'm showing the androgens, in men, the estrogens, the progesterone and the estrogens are exactly the same. I just wanted to highlight on the androgen part of men. We just give a few more dials in the visual for men's health. But the estrogen, the phase 1 detox, the phase 2 detox, and progesterone, we still give all those same results for men as much as we do for women. Now, we do look at Dutch extras. These, of course, are our nutritional organic acids and neurotransmitter metabolites for men and women. We give it report for both. So we look at B12, which we look at via methylmalonate, or MMA. We look at 2 B6 markers, being xanthuronate and kynurenate. We look at a glutathione marker, which is pyroglutamate. We look at a dopamine metabolite, which is homovinylate. We look at a norepinephrine epinephrine metabolite, vinylmandylate, or VMA, melatonin, and we look at an oxidative stress DNA damage marker known as 8-OHDG. Now, I do want to take a step back for the HVA and VMA. Please be aware 2 things. At Dutch, we use the 8 version of the name, so homovinylate, vinylmandylate, pyroglutamate. Whereas other labs you may be familiar with use the ic acid. So they will call it homovinylic acid, vinylmandelic acid, pyroglutamic acid. It's the exact same thing. It's just a naming difference, but you can use, it's the exact same thing. So if you have done a prior organic acid test somewhere else and you have a, pyroglutamic acid you're trying to compare, it's the same. Pyroglutamate and pyroglutamic, same. The other thing is that a lot of people confuse homovinylate, HVA, and vinylmandylate, VMA, as actual dopamine and actual norepinephrine and epinephrine, and they are not. They are the metabolites. And as we get into the clinical pearls, I will explain the difference and why it's important to know that. Please do not confuse HVA and VMA with the actual neurotransmitter. A lot goes into the production of HVA and VMA, and it just gives you additional insight. So speaking of those patterns, let's discuss some of those common patterns that you might see on the Dutch test to help evaluate your patients. And I am going to go into about 4 patterns because I want you to know just beyond the basics of low progesterone, sort of beyond the basics of low testosterone. I would say that a great number of you already know what to do if you see somebody who has low progesterone, how to support ovulation, things like that. But let's go into estrogen metabolism issues in men and women. So this is estrogen detoxification at its finest. So as a little recap, what does estrogen test, or what estrogens does Dutch test? We test all 3 estrogens, E1, E2, and E3. We test phase 1 metabolism. So we look at your 2-hydroxy, which is considered less carcinogenic. Please remember that 2-hydroxy is not no carcinogenic, and it's not healthy. It still creates quinones, and it can create adducts. They're just stable, which is better. The other bonus of the 2-OH pathway is that when it becomes methylated to methoxy, is actually healthy. It is actually helpful, and in some research, it's actually anti-carcinogenic. So the 2-OH pathway turning into 2-methoxy is where it's at, but the 2-OH itself is just less carcinogenic. The 4-OH pathway, however, is what's considered more carcinogenic. And the reason is if the 4-hydroxy veers off and becomes a quinone, which starts with a Q, that can bind to DNA, form an adduct, and break out of the DNA, leaving holes. Now, your DNA doesn't like it when there are holes in there, and your DNA repair system has to come through and repair all the holes in your DNA. If you have a few holes, which is normal in life, no big deal. Your DNA repair system can keep up with it. But if you have a lot of holes, if you have a lot of 4-hydroxy going down the naughty pathway, going down that other pathway and creating adducts, that's where you get into problems. Now, the 16-hydroxy pathway is a mixed bag. I'm sure a lot of people have been taught about the 2:16 ratio and how it has a lot to do with cancer. And it turns out the 2:16 ratio is largely debunked. It's definitely not as strong as they used to think. And the reason is they weren't taking in the 4-hydroxy pathway into consideration, which is much more carcinogenic. Now, the 16 pathway can cause proliferation, good for bone health, bad for breast cancer if you have it. It can increase proliferation. So, much like Goldilocks, it has to be just right. Your 16 pathway is what goes on to form estriol. So your estrone and estradiol can convert into 16, and then that can go on to form estriol. You can also form estriol out of estradiol as well. Once your body makes estriol, though, it is a dead-end estrogen. It does not go back. It does get excreted. So just FYI on that. Then we move on to phase 2 metabolism, which is essentially, can estrogen get, quote, neutralized and excreted out of the body? Can you go from a hydroxy to a methoxy where it is water soluble and able to get removed? So I teach estrogen metabolism as phase 1 on to phase 2 on to phase 3. But please remember, as a practitioner, treatment should always follow phase 3, phase 2, phase 1. You want to start with phase 3 before you move into phase 2, before you move into phase 1. Now, you can address them all at once, but don't just jump into phase 1 and hope for the best if phase 3 is blocked. Now, what do I mean by that? I'm sure if you've heard me lecture ever, you will know that this is my most favorite analogy that I say all the time. So Estrogen detoxification is like the bathtub. It's like a clawfoot bathtub, and it has to be clawfoot because I'm extra and I want a clawfoot bathtub in my analogy. So the water coming into your bathtub is your phase one. Is it 2 water? Is it 4 water? Is it 16 water? Is it filling up fast? Is it filling up slow? The drain is your phase two. Can the drain be open enough to get that water out? Is it not open at all? Is it plugged? Is it open but not open wide enough because just so much water is gushing into the drain? Now at Dutch, we don't look at phase three, but phase three is your sewer line out of your house. This is evaluated through stool testing. So water comes in your clawfoot bathtub, then the drain drains it out, and then it goes into your sewer line and out of the house, either connected to the city that you're in, or if you have a septic tank, if you're out in the country, then it goes out into your septic tank. So if you don't unplug your sewer line, then you are going to have problems. So if you just keep focusing on the water that's coming into your bathtub and you don't focus on your sewer line, what's going to happen? Your bathtub's still going to overflow no matter what you do. So you got to focus on phase three first, and then two, and then one. But let me give you an example. Let's say somebody absolutely needs phase one support. So this is a 2-week case of before and after diindole methane supplementation, or DIM. So this person, you can see it's the same person before and after. You can see on the left where I give you the frowny face, their 4-OH is in the red, their estrone is in the red, and their estradiol is in the red. And so that's not good. They're above the luteal phase ranges. 2 weeks on diindole methane, their E1 and E2 are down, and their 4 is down back into the green, and you get a smiley face. So for someone who actually needs DIM supplementation, they need phase one support, it can work wonders. Now, this is different than phase two estrogen detox, which is your drain. This is the ability to get from your hydroxy to your methoxy, and it goes through the enzyme COMT, which of course is made by your same SNP. Now, a lot of people say, oh my gosh, methylation, that must be through MTHFR, right? I must have MTHFR issues. You absolutely might, but this example is the same exact patient from the prior slide. So the person who was on DIM also needed support with their phase two. And as you can see, based on their SNP report, their COMTs are both homozygous plus. MTHFR, not a problem. That's not where the issue is. For them, it's COMT. And so it's COMT that donates, right? It's methyl donor to give you the 2-methoxy that you're looking for. Now, when you're looking at the Dutch test, methylation activity is a ratio of the amount of 2-hydroxy coming through at that particular time and the ability of it to get methylated into methoxy. So hydroxy to methoxy. In this example, it's not fast enough compared to the 2-hydroxy. So go back to my clawfoot analogy. The water coming in is coming in faster than the drain can get rid of it. Even though this person does not have massively excessive amounts of estrogen, in fact, they have kind of borderline lower estrogen levels, it doesn't matter. Their drain is still more closed compared to what they need. In this case, you would want to increase their COMT activity and really help with methylation. And so for those of you who, like maybe are new to genomics and new to SNPs, this is the pathway that I pretty much have burned in my brain. And whenever I talk about it, this is how I visually pull it up in my brain. So if you start at homocysteine on the bottom, homocysteine loops around to the left where you encounter your B12 SNPs and where methylfolate comes into the picture. And then it comes to the top where you become methionine. And then methionine keeps going around to the right where your MAT, your MAT enzyme, makes SAM. Now, like the supplement SAMe, right? We use the supplement SAMe. So SAM is a huge cofactor for your methyltransferases. Your other huge cofactor is magnesium. So SAM and magnesium are what help your COMT. They also help your PNMT, which I'll talk about in a little bit. And so this is where your methylation via COMT comes into play. And then, of course, the arrow goes back down around again, back to homocysteine. Now, the cut through, right through the middle from homocysteine to methionine, uses BHMT. And you can see like choline and betaine and zinc and dimethylglycine, DMG, or trimethylglycine, TMG, are all cofactors there. So when you're looking at this whole circle with your patient, you can see that there's numerous cofactors that go into making these. And of course, there are numerous things that can slow it down and cause a problem. So this is what I'm talking about when I'm talking about COMT and the methionine cycle. So phase 1 versus phase 2 treatment ideas. Phase 1, we're looking at primarily at diindolylmethane and indole 3-carbinol. And diindolylmethane is definitely my favorite. I have no financial ties to any DIM companies, but indole 3-carbinol has to hit your stomach acid. And once it hits your stomach acid, it breaks apart into multiple components, one of which is DIM. And so if you don't have very good stomach acid, and if you're on a proton pump inhibitor or something, then you may struggle to make DIM out of that indole 3-carbinol. So something just to keep in mind. If you have a low stomach acid person, maybe lean more towards the DIM as opposed to the I3C. For phase 2, we're looking at all those cofactors. So SAMe, P5P, which of course is active B6, magnesium, which is the other big cofactor for COMT, choline, methionine, your methylated B12s, your methylfolate, your trimethylglycine. All those can be really helpful for phase 2. General support, we're looking at liver support, calcium D-glucarate, which helps your phase 3. So again, we're not a phase 3, we're not a stool company, but when you're doing stool testing, not only are you looking for the good bacteria, the bad bacteria, candida, parasites, inflammation, what have you, but you're also looking for that enzyme beta-glucuronidase, and higher levels of beta-glucuronidase will cause higher reabsorption of estrogen. And so calcium D-glucarate can help with that while you're addressing the cause. Sulforaphane comes from glucoraphanin. Glucoraphanin and it's the enzyme myrosinase are in things like broccoli sprouts. So there's broccoli and then there's broccoli sprouts. So broccoli sprouts have the highest amount of glucoraphanin and myrosinase, and when they combine, they make sulforaphane. Sulforaphane is a really potent accelerator of NRF2, NRF2, so good for that phase 2, and really good for helping your 4-hydroxy that has sort of gone down that naughty quinone addict DNA damage pathway. It helps push it back to the beginning so that it can be methylated. So I'm a really big fan of sulforaphane. Glutathione and N-acetylcysteine also really helpful for redirecting that naughty pathway away from the quinones, away from the addicts, and of course is a very potent antioxidant in your body. Foods, again, brassica family, broccoli, kale, Brussels sprouts, broccoli sprouts, artichoke, onions, your high fiber foods, your fermented foods, all of those are really good for your estrogen metabolism from start to finish. I will say there is some interesting research that says you really can't eat your way. You can't eat it. Eating broccoli, eating kale, eating Brussels sprouts, very, very good for the body for a lot of reasons. But if somebody really desperately needs DIM to shift their phase 1 pathways, just increasing their kale count is not sufficient enough. They will actually probably need the supplement. There is research to show that people will have to eat many cups of it for every day for years before it becomes therapeutic. And so I still tell people, I still want you eating these foods, but if it doesn't make a dent, this is why, because you need much higher therapeutic doses. The other thing about DIM, just as a little clinical pearl, please do not give DIM or indole 3-carbinol unless you know their phase 2 is working, and of course phase 3, like I said, because you're just going to push more water into a closed drain or into a closed sewer line, and you don't want to do that. Now, the other thing about DIM, which I forgot to mention on here, is that you don't want to give DIM to a low estrogen person. If she's menopausal or maybe has amenorrhea and you put her on DIM, you run the risk of driving her estrogen lower because DIM does improve your phase 1, therefore it will pull estrogen out of circulation. And I see this time and time again where menopausal women are put on DIM and then they call their practitioner irritated because they're having hot flashes and night sweats and brain fog again when they thought those symptoms were done. So be very, very careful about using DIM in a low estrogen person, and maybe look at more your phase 2, your phase 3, and the other pathway stuff, sulforaphane, glutathione, and acetylcysteine. Next pattern are aromatization issues. So aromatization in men, men primarily, make estrone in their fat tissue, although they can do it other places, via the aromatase enzyme. And increased levels of insulin, having fat tissue already, high cortisol, alcohol, environmental toxins like BPA, and the fertilizer atrazine can all increase the activity of aromatase. And now men make more estrone. Now women can too, but in this I'm just focusing on men. Symptoms of increased estrogen in men: fatigue, low mood, low motivation, low libido, weight gain, breast development, erectile dysfunction. And these all sound like the symptoms of low testosterone, right? So many men go into their doctor and say, I have all these issues, I bet it's low T, and it comes to find out they actually have excess estrogen in their system. So here's a really great example. This is a true story. This is a man in his early 40s who's on testosterone injections weekly. And he said, I still have weight gain. I still have erectile issues. My libido is low and I'm tired and I don't understand. I'm on these testosterone injections. And you can see on the dial, his testosterone is 230. And this is reflective more of like the free testosterone in his body. And 115 is the cutoff. And when we looked at his whole estrogen, like, holy Moses, it has to go somewhere. His aromatase activity was very upregulated. His estrone up to 17.7, his estradiol up to 3.65 on the Dutch test. So I knew, I was like, okay, first of all, we either need to lower your testosterone injection or not do it weekly. And we have to address why your aromatase is so increased. Is it just because testosterone needs somewhere to go? Or do you have other things, insulin issues, stress issues, BPA use, and you don't realize it in your plastics? And so you can also use certain supplements and medications to help slow down that aromatase enzyme. Treating the cause is number one, of course. The common medications you'll see men on are anastrozole and letrozole. Anastrozole is Arimidex. But from a maybe in a herbal point of view or natural point of view, chrysin is a really good one. Chrysin is difficult to absorb orally. It's definitely better topically if you can do it. It's generally compounded. That can have really good effects, but you want your dose to be on the higher end. But white button mushroom. So I tell my men, eat white button mushrooms. Or you can take it as a supplement. The Latin name is agaricus. And so you can totally get agaricus and tell them to eat more white button mushrooms. And then grapeseed extract is another good one for anti-aromatase. Now, there are a lot of anti-aromatase uh, treatment options out there. These are just some pretty potent ones. So I just kind of list the more, the one more bang for your buck as opposed to just listing out like 15 of them. Next pattern, 5-alpha reductase dominance in men and women. What is 5-alpha reductase? Well, like I said, it is the enzyme that converts androgens into the potent DHT, the dihydrotestosterone, and those alpha metabolites like androsterone and the other 5-alpha stuff. Common symptoms, right? Cystic acne. Women get hirsutism, so hair growth in places they surely don't want. Male pattern baldness in men and women, anger and irritation in men and women. And it's increased via genetics. Some people have they already have an increased 5-alpha reductase activity. Inflammation, insulin, obesity, all these things can increase 5-alpha, just like they can increase aromatization, right? So we will often see sometimes in men, especially, higher estrogen levels and higher 5-alpha levels. In this case, though it's a female case, PCOS case, this is a female who presented with classic high androgen symptoms. Her practitioner ran all these serum tests on her in the blood, and her testosterone was in the normal range. So she decided to run a Dutch test, and you can see the Dutch testosterone is also in the normal range. But when we look down at the androgens and her 5-alpha pathway, her 5-alpha reductase was upregulated, and that was causing her symptoms. So it is still considered an androgen if you're following some of the, like the Rotterdam criteria for PCOS. She has high levels of androsterone, higher activity of 5-alpha reductase, and that's why she was having cystic acne, male pattern baldness on her head, hirsutism, things like that. So how do you reduce 5-alpha reductase? These are some examples. Obviously, address the cause, number one, always. In men, a lot of times they're given Advidart, which is a medication. Men and women can get finasteride. Be very, very, very careful of finasteride. It's for hair loss. There is a black box warning on it. Please Google finasteride syndrome if you don't know it already. It can be really nasty as suicidal tendencies or ideology is one of the known side effects, but it's still out there. But from a natural point of view, saw palmetto, stinging nettle root, pygeum, reishi mushroom, zinc, and EGCG from green tea can also all slow down that 5-alpha reductase activity. Now, you can use saw palmetto, stinging nettle root, pygeum, reishi, zinc, and EGCG on men just as well as you can on women. Women, you will often see that these supplements are in a bottle called something prostate, right? And so you're going to freak out and think, well, I don't have a prostate. I know, you just need the nutrients and the herbs inside. So it's effective for that 5-alpha. All right, last pattern, nutritional organic acids and neurotransmitter metabolite clinical pearl examples. Let's do B12, and we're going to do HVA and VMA as well. So methylmalonate on the Dutch test. And now with MMA and B6, if they're high, it actually means you have a deficiency. It's the opposite of what you would think when it comes to organic acids. So a high MMA means you have probably have a low B12. Methylmalonate is specifically adenylyl B12, not methyl, not hydroxy, but adenylyl B12. And adenylyl B12 is needed for mitochondrial health. So if somebody's having a lot of energy issues and you see a high MMA, really consider adenylyl supplementation or even hydroxyl B12 supplementation. Now, I do include, though, methyl B12 because if I see somebody with a high MMA, I'm going to probably assume that maybe all their B12 sucks no matter what, and we need to address it. So methyl B12 is part of that methionine cycle for the methylation of estrogen using COMT as it relates to the Dutch test. COMT, of course, is also responsible for dopamine converting into HVA, which I'll show you in a minute. And then norepinephrine to epinephrine uses PNMT. So I mentioned that earlier. PNMT is another methyltransferase, all part of the methionine or methylation cycle. And then norepinephrine and epinephrine both use COMT to create VMA. So it is important that B12 it's part of that bigger cycle, but then particularly adenylyl has a lot to do with your mitochondria. Pseudo-Dutch related for B12 at large, not necessarily adenylyl, but just B12 at large is a little reminder for you guys. It is needed to break down protein and fats to amino acids and fatty acid. It is needed to create succinyl-CoA for the Krebs cycle, which we talked about. It is needed to make methionine, which makes SAM, which methylates myelin sheaths and phospholipids. So if you have somebody with myelin sheath issues, keep B12 in mind. So let's move on to your HVA and VMA before we wrap up this webinar, just to give you a taste, one last taste of some clinical pearls on the Dutch test. So for those of you who need a little neurotransmitter metabolite pathway review, I have how things are made, including the coenzymes with it. So if we look at HVA, homovinylate, this is a dopamine metabolite, but it's not 100% indicative of dopamine because you have to look back at the rest of the pathway. So if somebody has low HVA, is it because of a dopamine problem, or is it because of a B6 problem, an iron problem, a biopterin problem, a tyrosine problem, a phenylalanine problem? It just gives you an idea that there's something going on that pathway. To make VMA, vinyl mandylate, you have to look kind of at the entire pathway because VMA comes from epinephrine and norepinephrine, but it requires SAMe and cortisol, and of course that PNMT to make epinephrine. And then if you go back a step, it requires copper and vitamin C for that DBH enzyme to work. And actually a huge inhibitor of that enzyme is C. diff, Clostridium difficile. So again, those of you who are doing stool testing, be on the lookout for that little bugger because it can definitely slow down the conversion of dopamine into norepinephrine. And then we just go back from there. If they have B6 issues, they're going to struggle to make dopamine. If they're anemic, they're going to struggle to make L-DOPA, and so on and so on. So please do not say HVA is a direct representation of dopamine. It's just on the pathway. Now, having said that, you may also have SNP issues. So COMT and MAO are responsible for breaking down dopamine, norepinephrine, and epinephrine into HVA and VMA. So you may have somebody with a slow COMT or a slow MAO. Therefore, they're going to have low levels of HVA and VMA. This, and if you've heard me lecture before, this is my best friend. My best friend has low levels of MAO. When she gets stressed out, her norepinephrine and epinephrine go up, and then her slow MAO can't break them down into VMA, so she can excrete them. So she feels stressed out, nervous, and anxious the whole rest of the day. I'm over it. I'm over the stress and moved on, and she is still, shaking like a chihuahua and can't figure out why she's so stressed out. And but we know now that she has MAO issues. And so it's entirely possible when you look at your HbA and VMA, it's completely correlated to your COMT and MAO. And we know your COMT is very important for phase 2 estrogen metabolism, converting your 2-hydroxy or 4-hydroxy into a methoxy. Very important. So let's summarize this webinar as we come to a close. Please know your HPO and HPG for the men starts up in the brain. Your test collection, ladies, should occur 5 to 7 days after ovulation, hopefully assuming that you ovulate. And if you are menopausal, then you can test collect anytime. And same for men. Men, you can obviously test anytime. We do highly recommend that you test on a normal day. Please do not test on an off day, on a sick day, on a vacation day. If you want to see you normally, then pick a normal day. Please remember, estrogen metabolism is a phase 1, 2, and 3 process. Phase 1 and 2 are done in Dutch testing, but as you know, you want to address the sewer line first, then the drain, then the water. So make sure you are addressing it as a 3-2-1 process. Aromatase in men and women can be upregulated with obesity, inflammation, and some environmental toxins, so address that. 5-alpha reductase is what pushes the more potent androgen pathway known as DHT or androsterone. And similar things upregulate that, such as inflammation, cortisol, environmental toxins. And then the Dutch extra markers just add more information for the case. It just gives you more clues as to what's going on or what other pathways you have to go down, literally and figuratively. And lastly, comprehensive testing puts all those puzzle pieces together. So having the most comprehensive, easy to collect adrenal and hormone test available with the Dutch extras allows you to make greater impact on your patients at a deeper level. And that deep level is absolutely what we're going for. So thank you so much to everyone for listening. Again, thank you so much for In Common Laboratories and of course, Dutch Test, Precision Analytical. And we will open it up to questions. So it said, we do actually have a question. What does it mean if a woman is postmenopausal, if a woman in postmenopause is in the non-menopause range for all the estrogens? And it depends, okay, non-estrogen or non-menopause range, meaning she's in the luteal range or she's below the menopausal range. So if she's below the menopausal range, then that poor postmenopausal woman is low, the poor thing. If she's postmenopausal woman and she's higher than the menopausal range, higher than what you expect, then there is something going on. She's either supplementing on estrogen, she's getting estrogen somehow and not realizing it, like transference. If she's maybe on supplementation that you're doing, then that can drive it up. And it also depends how much higher. So if she's postmenopausal but in the luteal range, versus postmenopausal but in the sort of gray area range between the star and the box. But also please keep in mind, detox plays a huge, huge role. If she has a lot of gut issues, then the body will reabsorb and recirculate that estrone and estradiol back into her system. And I have definitely seen that when women have higher levels of beta-glucuronidase, that when they get that addressed, then their estrogen levels drop back into a more normal range. Let's see here. What are the symptoms of phase 1 versus phase 2 estrogen detox issues, or can you find out via testing? Unfortunately, the symptoms are the exact same. That's a great question. They're generally the exact same, unless you already know their SNPs per se, like if you've already run some testing and you know they have COMT issues, then you'll probably start there. But the symptoms are that of general estrogen dominance, which is not helpful. It doesn't help you know if they have phase 1 or phase 2 or even phase 3 issues. Although phase 3, they'll probably have gut issues. So testing is the only way to know the difference between them. And keep in mind, a lot of men and women have both. They have issues with their cytochrome P450s, right? Their CYP1A1 or 1B1, and they have issues with COMT. And so you end up treating both at the same time. But if I knew magically how to tell the difference and avoid testing, I would just tell you because it would be easier. So um, what can we do to support a slow comped or slow MAO? So the slow comped, actually, if you go back, I'm just going to move all the slides back. I have it all listed out. So there you go. How do you support a slow comped? You're looking at and this is just a superficial look at it. I highly recommend it, maybe if you're new to SNPs, to really start to dive in and learn about COMT, because a lot of things can slow it down in the first place. But here's just general support. So SAMe and magnesium. Magnesium is usually my top go-to. And then P5P, choline, methionine, methylated B12, folate, trimethylglycine. So basically what you'll do is you'll study this methionine cycle, and you'll try to figure out either through elimination or through doing genomic testing where things are going wrong. Or maybe you already know they're probably magnesium deficient, or maybe you already know that they have issues with zinc, or maybe you already know that they have issues, their HCL, their betaine is not great. Maybe you already know you've done B12 testing on them, and you know their methyl is low, you know their adenosine is low, and then you're going to address that. And so you're just going to study this cycle, and that will help at least start you with COMT. But COMT it's kind of a large topic. So we'll just leave it at that, since just because of time. Are there any other questions? These are great questions. Thank you. Let's see here. Do you expect someone to have a normal progesterone while good question, while on the Mirena IUD for years? What could be the reasons? Great question. And I should have said this earlier with the birth control. So any of the progestin IUDs, the Mirena, the Kyleena, the Skyla, if you read the package insert, they say right in there that it can partially or fully suppress ovulation. Unfortunately, we don't know if they partially or fully suppress ovulation until they test. So sometimes you can tell via symptoms, right? You can tell if somebody's not ovulating. You can do ovulation predictor kits and they're not positive. So you're like, all right, well, they're not ovulating. But a large percentage of women who have a progestin-only IUD do struggle with ovulation. Therefore, they have low levels of progesterone. I will often get asked then, well, can I just give them, B6, and can I give them chase tree berry to bring that up? You can try, but you're working against the Mirena, and medication, that's strong. Medication's tough to trump herbs and nutrients sometimes. So we don't usually see it work, but we do see the low progesterone, and we don't know until testing. Now, the copper IUD, the Paragard, to our knowledge, does not have the same effect on any of the hormones. Yes, I fully am aware copper can raise estradiol, but we don't tend to see that on testing enough that I pointed out as a common pattern. The progestin IUD we see all the time, so much that I usually point it out. So I'm glad you asked that question. The copper IUD, I do not tend to see it cause overwhelming estrogen dominance all the time. But you can, test to know. Test to know. Test, don't guess, right? What is your go-to estrogen detox plan? You're in luck. I have an entire lectures about that on the Dutch website. I have a 2-hour lecture on estrogen detox where I lay it all out. And so that's what I would recommend you check out, because it's different if it's phase 1, phase 2, or phase 3. I do look at all the 3 different phases and then address them accordingly. So I'm going to address gut health differently than I'm going to address phase 1 cytochrome P450 issues. Let's see here. Next question. I have a patient with menorrhagia and fatigue, presented like low progesterone, high cortisol in history. Dutch testing showed high progesterone, low normal cortisol, high estrogens, all 3, high DHEA, and normal testosterone. Oh, good gracious. This poor woman. Where? Oh, here. Would you suggest starting with supporting adrenal function or the sex hormones detoxification pathways looking well? So she already has menorrhagia with fatigue, with low, so she has low progesterone, high cortisol history, but on Dutch testing, she has low normal cortisol. So that's probably in part explains the fatigue. Obviously, there's other hormones that go with fatigue. With menorrhagia, I'm hoping she's not anemic, and I'm hoping you've had her worked up for things like fibroids, polyps, adenomyosis, things like that. And definitely, I'm hoping you've worked her up for PCOS, if high DHEA, potentially, even with normal testosterone, if she's a 5-alpha person, that can sort of mask or be tricky with the PCOS, like I showed. So where would I start? You could honestly, I guess it would depend on the answers to everything I asked. If she has fibroids or adenomyosis or polyps, then obviously I would address that differently than if she already has high estrogen, then like she doesn't appear to, even with detox pathways looking good, if they're in good balance, they may need to be faster. So having good ratios but not being fast enough could still be an issue. If you've done gut testing on her and you know what her gut health looks like, that could be really helpful, because if she has high levels of beta glucuronidase, then she is just reabsorbing all that estrogen, and that is just contributing more to her symptoms. So super, super great question and interesting case. I have like a million more questions to it though. So where would you start? It sort of depends on what the answers are. So you're completely welcome, of course, as a practitioner, to schedule a Dutch using practitioner. You can schedule a consult with one of the doctors here, or call In Common Laboratories and talk with Dr. Prouse about this case in particular, and they can, like she or we can absolutely like help walk you through it. Last question. You said you don't give DIM without phase 2 working well. So can you give DIM with something specific to ensure phase 2 will be aided? Yes, totally, absolutely. So if you're, think of it, remember, water coming in your bathtub and drain. So if I'm doing things to make sure the drainer is open, so if I'm doing phase 2 support, COMT support, or I already know they don't have COMT issues, their COMT, their methylation looks good on the Dutch test, I will, then you can use DIM in that case, or I'll use DIM and COMT things at the same time. But the reason, again, I don't use DIM by itself unless I know phase 2 and phase 3 are working, is that you'll just increase the water in the bathtub. Now you're going to increase the 2 water, right? The 2 hydroxy water, which is less carcinogenic, which is great, but you still don't want that water to overflow. Like you still don't want too much 2 hydroxy water that then overflows, because the phase 1 metabolites, all phase 1 metabolites in your body, because we're talking about estrogen, but anything that goes through phase 1 becomes a reactive oxygen species, and that's the problem. I don't want 2 hydroxy still floating around causing issues, and it still can turn into an addict. It's a stable addict, which is much better, but it's still an addict and is concerning. So just be aware of that with DIM. Okay, everyone, thank you again so much. We really appreciate it. Thank you again to In Common Laboratories, like I said, and to Dutch Test, and I hope you learned a lot. If you have any questions, please definitely call In Common, and they can answer absolutely everything for you. So have a great rest of your day.